One of the things, these are kind of simple adages to guide you through a complex day. One of my teachers from medical school said, if you remember anything from this rotation, I want you to appreciate that it's hard to improve on an asymptomatic patient. Think about that for a minute. Someone will come to you and say, well, they've got some bug in their sputum. And you talk to them and they say, I don't cough, I don't feel bad. Some doctor just got the sputum test on me, I don't know why, and the darn thing showed up positive, but now they say I should be treated. And I must say that this is a reasonable adage to keep in mind, that if you're asymptomatic, I probably can't improve you. And I can make you sicker than hell from the medications, which is the other side of it. The x-rays are troublesome because we do x-rays and CAT scans now all the time at the drop of a hat. You can barely get into a hospital these days and not have some imaging of your lungs done. And so we do it, and then something shows up, and then we're charged with understanding it. And so we look at it, this is easy. When you got a big hole in your lung, there's no quarrel, there's no discussion. We go ahead on the presumption of active disease. Bronchiectasis is really where we are kind of in this emerging area of understanding. Bronchiectasis, literally from the Greek, bronchi is the airway, ectasis is dilation or distortion of the airway. So it's a traditional way to say that the bronchial tree, this is a wonderful time of year to be a tree watcher. You can go outside and you can look at the tree before the leaves obscure the airway, the bronchi, the trees, the branches, whatever you would imagine. And instead of having nice, slender, tapering tree branches leading down to twigs and at the end of the leaf, you're looking at airways that are distorted. The Greek word ectasis. And the design of our lungs is such that we need to have this gradual tapering anatomy, because once you dilate the airways, you disrupt the clearance of mucus, you beget chronic infections. The areas that are most commonly involved for reasons we don't understand are the right middle lobe, or the analog to the right middle lobe, which is the lingula, from the Latin word tongue. It's a tongue-like protrusion of the left lung wrapping around the heart, or it may be scattered around. And so we see that, and we know we're probably up against NTM disease. Cultures we do spontaneously, or we induce sputum. Bronchoscopy is done because we can infer. Most of the clinicians who see these cases tell me a patient's got chronic recurring cough, who's got an abnormal CT scan with bronchiectasis and nodules scattered around. We'll say that's an NTM case. But it's not enough to know that. You have to know the species, because the treatments are radically different. Susceptibility testing, I said, is of uncertain utility. We do it at National Jewish. We think it's useful. I've been involved with debates before, and I'm sure that there are many who are non-believers, with the exception of a few drugs. The regimens we typically see with MAC regimen, we use these three drugs: macrolides like clarithromycin or azithromycin, rifamycins like rifampin or rifabutin, ethambutol. That's your standard three. Substitutes coming off the bench include the fluoroquinolones, Cipro or Moxie, and then amikacin, which is a drug given intravenously or by inhalation. And it is frustrating that we've added no new drugs since the fluoroquinolones, which are now, 15, 20 years old? And so we're desperately casting about for new medications. Kanzazi we don't even talk about, because that's an easy infection to cure. Relatively common, easy to cure. This is where the rubber is meeting the road, that those of us who work in the field, I think, have been largely struck by the progressive appearance of rapid growers like Mycobacterium abscessus. It is, well, I think without question, the most difficult of this group of infections to manage. predictably, we can very rarely anticipate cures. The cures that we see are usually patients whom we see early on who've got limited disease, whom we can treat intensively and take out the visually damaged lung. But the options for therapy are pretty limited. Clofazimine is a drug of modest activity. Linezolid and tigecycline are new antibiotics, which have in common they are really hard to take. We can take an infection, it requires 2 weeks, and ask a patient to endure the misery associated with tigecycline, or to get into the neuropathies or bone marrow suppression related to linezolid. But when we're looking at months and years, it is increasingly difficult, I think, to sustain those therapies. The issues with our treatment, one of the things we look at is, do we just drop all the patients on all the medications on the patient at once? I have come to the notion that we can really, in a Pavlovian way, condition the patient to be absolutely frightened of and miserable with the drugs if we start all the meds at once and they are just devastated with nausea. And so I'm inclined to use the drugs one at a time for a week and try and sneak up on the patient and condition them to tolerate. Daily or thrice weekly is an important question. Most people clearly appreciate 3 times a week if it can be of equal efficacy, but we're not sure exactly. And coping with the side effects and toxicity is really the greatest challenge. I must say, all of you who've tried, who've endured all these medications, the side effects, appreciate that this is not a trivial thing. Closing with surgery. Why do we do surgery? Well, coughing of blood is one of the indications that historically coughing of blood was seen in Act 4 of La Bohème, La Traviata, and other operas in which the heroine coughed a lot of blood, sang a lovely aria, and then died on the stage of consumption. And I've always thought, well, probably if she's nearing death from hemoptysis, she couldn't sing very well, but that's all right. We'll give the author some slack. Symptom relief is another indication if patients are devastated with relentless cough and phlegm. We also look at a patient in whom we say, given the nature of the infection, the resistance pattern, we're unlikely to cure them, and yet the disease is finite, and we will make a difficult decision to run the risk of surgery. And the option to cure if we're fortunate to catch the patient early on. The thing that's jumped up now as a source of our rumination, that's a good play on words. If you're a farmer, you know what's rumination? It's where cattle chew their cud and they reflux their cud up out of their stomachs to ruminate on it. And so reflux and aspiration is really, I think, a major question. We, at some point, said that our history taking wasn't sufficient to distinguish what patients should be studied or not. So we just do it routinely on all patients who have these infections. And it's been startling to us that probably 75% or more patients have reflux. We don't always see aspiration, but we assume if there's recurrent reflux, aspiration is just a matter of time. And the question, this is another chicken and egg, Leah. Do patients develop bronchiectasis due to reflux and aspiration? Or do patients with bronchiectasis who cough relentlessly generate insufficiency of the esophagus? I want you all to think a little bit as you're sitting at your seats now, what do you do when you cough? What's the cough reflex consist of? When you get the tickle in your throat and you know a cough is coming, somehow you're programmed to take a deep breath in, close your epiglottis, And then you generate the force of a cough with your abdominal muscles. The cough doesn't come from your diaphragm, it comes from your abdominal muscles. They contract violently. It increases the pressure in your abdomen. That pushes up in your diaphragm. And what that does is increase the pressure, and eventually your glottis opens up, epiglottis, and the air rushes out at a very high speed. But to generate that, there's a tremendous pressure on your diaphragm, and it probably puts you at risk of herniating your stomach into the hiatus where the esophagus passes. And so I think that chronic coughing can actually result in dilation of the lower esophageal sphincter, leading to reflux and aspiration. And so I think it is both chicken and eggs. But whatever comes first, it is essential that we recognize and manage this risk. I want to thank you all, most of all, the godfather and the godmother of this enterprise, Phil and Fern. They say, oh no, it's nothing. They make it all happen. They sustain us all. God bless you, and thank you very much.